Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. We continue our playlist called Pulmonology. In the previous video, we talked about DLCO, or diffusion capacity of carbon monoxide. Today I'll talk about the flow volume loop. Flow on the vertical axis, volume on the horizontal axis. Don't confuse flow volume loop with pressure volume loop. With that being said, now let's get started. First, let me help you by answering the previous case from the last video. By the way, the previous 13 cases are again in this playlist called Pulmonology. Okay, 35-year-old male comes in complaining of dyspnea, diplopia, and ptosis. He also says that he cannot chew a cracker and he feels his mouth is so dry. Sexual history is relevant for inability to conceive for more than 18 months, even though his wife has been pregnant before from a previous marriage. 7 years ago, he worked part-time in a coal mine for just 2 weeks. On physical exam, there is a weakness of the extraocular muscles, strength of the proximal muscles in lower extremities, and ptosis. You ordered pulmonary function test, and the results are as follows. FEV1 is reduced, FVC is reduced. FEV1-FVC ratio is 94%. TLC is decreased, VC is decreased, RV is decreased, DLCO is normal. Now let me ask you this. Do you think this is an obstructive lung disease or a restrictive lung disease? I want you to pause. If you look here, FEV1 and FVC are reduced. FEV1-FVC ratio is increased. All of the lung volumes and capacities are decreased, and DLCO is normal. From this, we deduce that this is a restrictive lung disease. But there's a question. Is it intrinsic or extrinsic? Is the problem in the lung itself, or is the problem outside of the lung, such as the chest wall, the neuromuscular, etc.? Next, then we look at the DLCO. The DLCO is normal, which means it's the problem from outside of the lung. The lung is normal, that's why the DLCO is normal. So it's coming from outside the lung. Now let's digest that. You have dyspnea, diplopia, ptosis. Seems to me like a nerve problem. He also is failing to conceive, and his wife is normal, so it's a problem in fertility. Problems with extraocular muscles, and decreased strength of muscles, ptosis, and extrinsic restrictive lung disease. And also there is dry mouth. Do you know what this is? This is Lambert-Eaton myasthenic syndrome. First question, which of the following is the likely underlying pathophysiological mechanism of this presentation? Please pause. And the answer is B, anti-voltage gated calcium channel antibodies on the presynaptic neurons. So here is the presynaptic neuron, and here is the postsynaptic. Okay, here we have calcium channels, and here we have acetylcholine receptors for the acetylcholine to bind. If there is a problem or antibodies against the calcium channel, this is Lambert-Eaton myasthenic syndrome. If there are antibodies against the acetylcholine receptor at the neuromuscular junction, this is going to be the myasthenia gravis. Since this is a Lambert-Eaton myasthenic syndrome, it's going to be anti-voltage gated calcium channel on the presynaptic neurons. Okay, why not myasthenia gravis, since myasthenia gravis can also lead to an extrinsic restrictive lung disease? And the answer is this patient was a male, there was a dry mouth, there was infertility, so it's more likely Lambert-Eaton myasthenic syndrome. So A is myasthenia, B is Lambert-Eaton, which is the correct answer. Co-worker pneumoconiosis? No, he only worked part-time for 2 weeks. No, it's not enough. Ferruginous bodies? This is asbestosis. The case didn't mention his exposure to asbestos whatsoever. Reactivation of TB? This requires immunosuppression, and I have no clue that he is immunocompromised. Defective CFTR? This is cystic fibrosis. No. Yes, cystic fibrosis can happen in a 35-year-old male. Okay, it's a chronic problem and they are treated well in these days, but it's not going to have ptosis, it's not going to have diplopia, it's not going to have proximal muscle weakness, and cystic fibrosis does not have a restrictive pattern. it has an obstructive pattern due to bronchiectasis. Defective dynein arm from the cilia, this is Cartaginer syndrome. And it's not going to lead to dyspnea, diplopia, ptosis, and proximal muscle weakness and dry mouth. It's not going to lead to any of these. It's going to only lead to infertility. Next, which of the following should be done for screening purposes? Please pause. And the answer here is B. CT scan of the chest and abdomen. Why? To rule out lung cancer. Because if you have Lambert-Eaton myasthenic syndrome, you are more likely to get lung cancer, especially small cell lung cancer. Chest x-ray to check for thymoma, this would be true if this is myasthenia. CBC, CMP, no. Serum uric acid level, this is not tumor lysis syndrome or a hyperuricemia or gout. Serum ACE, this is not sarcoidosis. Serum calcium level, this is not sarcoidosis. And it's not squamous cell carcinoma of the lung, this is small. And as you know, hypercalcemia is more common in squamous cell lung cancer. Third, previous screening test was negative. Which of the following is the best management option? Please pause. And the answer here is C. Plasmapheresis, immunotherapy, and pyridostigmine. Pyridostigmine is an acetylcholinesterase inhibitor. Plasmapheresis to try to dilute or mitigate the effect of the antibodies. You give him new plasma that doesn't contain the anti-voltage-gated calcium channel antibodies. Immunotherapy, of course. Okie dokie, I have an important announcement for you. Some of my videos are premium videos. Translation, they are not available on YouTube. You should go to patreon.com/medicosis if you are interested. And from the left side called feature tags, just click on videos premium. Okay, right now I have two. One of them is about lymphatic drainage, and this is like 31 minutes long. It's like detailed anatomy of the lymph nodes. Where do they drain? How about the cervical chain? How about the axillary chain? How about the inguinal, the femoral lymph node? All of this crazy stuff. Also, I have another video called Chronic Myelomonocytic Leukemia. Okay, flow volume loops. Here is the first type. Time is here and volume is here. Volume over time happens to equal flow. So the slope of this curve is the flow. Don't forget, compliance was delta V over delta P, not delta T. Slope, again, delta y-axis over delta x-axis, which equals delta V over delta T, which equals flow. The maximum slope of the flow curve, i.e. the greatest angle theta, okay, is called peak expiratory flow rate or PFTR. This red line, that is the highest or the greatest slope. Translation, the highest flow. Translation, the highest delta V over delta T. Here's a question for you. Which of the following straight lines represent the peak expiratory flow rate? A, B, or C? Please pause. And the answer is whoever has the greatest angle. The biggest angle, okay, this is going to be the A, man. So A is the peak expiratory flow rate, or PEFR. Don't ever forget that. At the PEFR, the flow is the greatest. So again, PEFR is here. This is the maximum slope of the curve. FVC is here because if you remember, I asked the patient to inhale maximally and exhale maximally and quickly. This is the FVC, the highest thing. After 1 second, this is the FEV1. So this is the volume expired after 1 second. This is the volume expired, like no matter what. I mean totally. So here's the flow volume loop, which makes students lose their God-given mind. Please pay attention. You ask the patient to inhale maximally and then exhale maximally and quickly because it's timed. It's FVC. This is the inspiratory curve and this is the expiratory curve. So during expiration, in the beginning, there is increased flow. Early on during expiration, there is an increased flow rate. How do you know? Because there is upward deflection of this curve, and this is flow over volume. As I move from here to here, the flow is increasing and the volume is decreasing because you're expiring. You're getting the air out of your lung. No wonder why the volume is decreasing, because you're getting the air out, so the volume remaining in the lung is decreasing. but the flow is increasing. The first second is the best, very strong flow. But then the later seconds the flow is decreasing and the volume continues to decrease. Next, let's talk about the inspiration curve. You ask the patient to inhale maximally and quickly. Again, flow increases. Okay, don't say, oh, this is just like, this is -4 and this is lower than -2, so the flow is decreasing. No. It's the opposite direction. It's a vector in mathematics. So the flow is increasing, but it's in the opposite direction. Flow increases in the beginning, then flow decreases. And in economics, this is called the law of diminishing marginal returns. At some point, you cannot just increase the flow to oblivion. You will start decreasing it back. It's like when you study. If you study like, let's say 10 hours, you can score 30% on your exam. But then if you study another 10 hours, this is just gonna make you score 40%. Another 10 hours, you get to like 45%. Another 10 hours you get to, okay, that's why it's very hard to get to the top, because of the law of diminishing marginal return. Here's a question for you. From this flow volume loop, match from column A the predicted value in column B, the residual volume, the total lung capacity, and the FVC, and here are your choices in ml. Just match if you know the answer. Now please pause, and here is the answer. The expiration curve is here. You're asking the patient to exhale maximally until the patient cannot expire anymore. Whatever is left in the lung that cannot be expired is the residual volume. So the residual volume here is about 1200. Next, what is the total lung capacity? Here is the volume in liter, and when the patient inspired to the fullest, he reaches the TLC, which is here. So the answer is gonna be 5800. Third, what is the FVC? This is so easy. The FVC is the difference between the total lung capacity and the residual volume. Remember the vital capacity? This is the same as the vital capacity, it's forced. So on the graph, it's gonna be from here to here, from here to here. And this is about 4600, because 5800 minus 1200 is about 4600. Now please pay attention. This is a theoretical question. It's not actually true. Why? Because the flow volume loop is done via spirometry. And I've told you before that spirometry cannot measure the RV or the TLC. This is just a rough and dirty estimate. I'm just forcing you to think and use your God-given mind. Here is another question from this flow volume loop. Match from A to B. What is the peak expiratory flow rate in liters per second? Is it A, B, or C? Now pause, and here is the answer. The peak expiratory flow rate is the peak expiratory flow rate. It's the greatest flow, and here it happens to be equals 8 liters per second, which makes C the correct answer. So easy, it's unbelievable. So now, flow volume loop. Inspiration is here, expiration is up there. The highest point on the y-axis is the PEFR, peak expiratory flow rate. Okay, the residual volume is here. It's whatever is left in your lung after maximum forced expiration, and the TLC is here. It's whatever is in your lung after maximal forced inspiration. Now, since you know the normal already, let's talk about obstructive lung disease. What happens in obstructive lung disease? I cannot get the air out. I have a barrel chest. The residual volume is increased. See, this was like 1200 or 1 liter 0.2. This is more than 2 liters, so there is increase in RV. There is increase in total lung capacity, so the curve is shifting outwards. The TLC is increasing. Instead of 5800 or 5.8 liters, it's more than 6 liters. If you have an obstructive lung disease and you cannot get the air out, of course, the flow rate during expiration is going to decrease. That's why this peak is less than this peak. And also there is coving of the expiratory curve. Okay, you don't see this coving in cases of normal. Inspiration is relatively normal, like slightly reduced, but it's not a big deal. Now let's talk about restrictive lung disease. Remember, in restrictive, I'm restricting from filling. I cannot get the air in. Therefore, all of my volumes and capacities of the lung are decreased. So RV is decreased. It's less than 1 liter instead of normal, which is 1.2 liters. TLC is decreased. It's less than 5 liters instead of 5.8. PEFR is decreased. Why? If you have less air coming in, you have less air coming out. It's called common sense. And the inspiration curve has a lesser flow if you compare it with normal. Here was like more than 4, here is about 3. And there is no coving because you have no problem during expiration. You have great fibers in your lungs called fibrosis. It's easy for you to get the air out. Both obstructive and restrictive lung disease, the problem was in the freaking lung. What about the problem in the fixed upper airway obstruction? So now the problem is in the upper airway, trachea or goiter or something like that. You have flattening of both the inspiratory and expiratory limbs. Let's say you have a tumor in your larynx or trachea. The air cannot get in, and for sure as heck, the air cannot get out. You have decrease in the expiratory curve and decrease in the flow in the inspiratory curve. Your residual volume is increased because you're obstructed, you cannot get the air out. For the last time, flow is here, volume is here. Expiration is here. What is this point called? Peak expiratory flow rate. Now the patient expires. Then the patient inspires. All right. Until he reaches the total lung capacity. So after expiration, what is this point? This is the residual volume. Between them, this is what? This is the forced vital capacity. Let me draw an obstructive lung disease curve. Okay, you have increased residual volume, so let's start from here. You have increased TLC, so let's start from here. And you have decrease, especially during expiration. So it's going to be like this. There is coving, so it's going to be like this. The inspiratory limb is decreased, but not so much. Okay, we get it. This is an obstructive lung disease. Let's do a restrictive lung disease. All of my volumes and capacities are decreased. The residual volume is going to be like here. And the TLC is going to be like here. Let's match them together. During inspiration, I have the most problem. The curve is very low. And during expiration, I'm also having a problem, but it's kind of like this. It's usually higher than the obstructive lung disease, but still lower than normal. So the highest PEFR is the normal, the second highest is the restrictive, the third highest is the obstructive because you are obstructed, you cannot get the air out. If I can summarize this entire freaking lecture in just one slide, here it is. Normal is here. Okay, obstructive lung disease is here. It's gonna shift it to the left. Restrictive lung disease is here. It's kind of shifted to the right. Fixed upper airway obstruction is here. All of everything is decreased. The crazy mnemonic is restrictive lung disease is shifted to the right. To the right. That's a restrictive lung disease. In case you have like an amoeba for a brain, this is just a mnemonic for you. So on your exam, you can just answer it in 3 seconds without understanding anything. Forgive my language, I'm just messing with you. Okay, now we get it. We can use those flow volume loops to diagnose obstructive lung disease. But is it asthma or is it COPD? Solution, give a beta agonist or a bronchodilator. If it improves, it's an asthma. If it didn't improve significantly, this is COPD, because COPD is a fixed obstruction. Asthma is a reversible obstruction. Now let's connect the dots together. First, how to diagnose an obstructive lung disease? You go to the FEV1-FVC ratio. If it's less than 70%, you have the diagnosis, it's an obstructive lung disease. Then, how you determine the severity? Look at FEV1 alone. 50 to 80%, this is moderately reduced. 35 to 49, severely reduced. Less than 34% is very severely reduced. Now I know it's an obstructive lung disease and I know the severity. But is it asthma or is it COPD? Give a bronchodilator, a short-acting beta agonist such as albuterol. If FEV1 improved significantly, that is a reversible obstruction, it's asthma. If it didn't increase significantly, it's a fixed COPD. So here is flow volume loop. The black curve is before giving a bronchodilator and the blue curve is after giving a bronchodilator. You see, normally there is a change, but it's very teeny tiny and it's minimal. Yes, if I give you, my normal person, beta-2 agonists such as albuterol, you'll improve your flow, but not too much because you are already normal. But now look at asthma, man. Look at this improvement. Look at this. This is significant improvement. This is significant increase even in the peak expiratory flow rate. This is increased in this curve. There is no coughing anymore. That's an asthma. This is never a COPD. Now look at the COPD, fixed obstruction. Even after you give bronchodilator, the response is minimal. It is dismal. It is trivial. It is negligible compared to asthma. Now let me leave you with a case which will be answered in the next video, but you can let me know the answer down below in the comment section. Which of the following graphs represent a patient with a phrenic nerve injury? And the letter corresponds to the color. So is it A, is it B, is it C, D, or E? Let me know the answer in the comment section. I know that you're struggling to learn about Legionella, Mycoplasma, Pseudomonas, Rhinovirus, Klebsiella, Staph, Strep, and E. coli. Please check out this website. It's called Picmonic. The link is in the description below. Thank you so much for watching. Please subscribe and join the tribe. Hit the bell to get notified. Follow me on Facebook. I have more than 100 cases there. Please support this channel on Patreon to get my premium videos and my notes and my cases and everything. Thank you so much for watching. As always, be safe, stay happy, and study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense. Until next time, in the next video, we will talk about ventilation and then perfusion and the VQ mismatch. See you then.